I trust you've seen the lava pits and the banners advertising the new TMA Calendar of Doom. As bad as it sounds, I'm quite hopeful that the Calendar of Doom will be a good thing, a very good thing for you and all Texas physicians. I think it will be good because the demands to comply with growing state and federal regulations are so onerous, and because so few of us are really prepared for it all, the Calendar of Doom will provide a great opportunity for TMA to demonstrate tremendous value to our members. The thing that bothers me most about the whole regulatory landscape is that we all know that we are destined now to become the most regulated industry in America, and with it, more regulations comes increased cost, and that's going exactly in the wrong direction. Here's why we have a problem. By show of hands, how many of you have successfully written 10 electronic prescriptions by June 30th? That's quite a few. And those of you who know, some of us, like orthopedic surgeons who write primarily pain medications and use over-the-counter non-steroidal anti-inflammatory agents, have very few opportunities to do that, and it can't be a renewal. It has to be a patient, or not a new patient, but a patient visit. So I've actually applied for the exception. You can do it online. It's not that easy. And then the thing that most amazed me is when I did it, they told me that the volume was so high they weren't sure they were going to be able to get to my exception by the expiration date, which is a month and a half away. So the answer is they may actually fine you, and then you have to do an appeal even if you've done the right thing. So you need to pay attention, get online, and get the exception. And you can qualify for one of the hardship exemptions that TMA and others have convinced the Centers for Medicare and Medicaid Services to offer. You have until November 1st. That's Tuesday to claim your exemption. It's not a month away. How many of you know about the exemptions? Does everybody know about the exemptions? Great. How many of you have filed for an exemption? I ask how many have done it. How many of you have filed for an exemption? Well, that's a pretty small number. That surprised me. Maybe you all are doing a lot better than we think. The Calendar of Doom, ladies and gentlemen, will make sure you know about these deadlines. We'll make sure you know what happens if you miss these deadlines, and we'll give you tools to help you comply. Or consider this. Last month we conducted one of our TMA teletown hall meetings to educate members on a much more serious deadline. If you don't upgrade your electronic billing system to comply with the new HIPAA 5010 electronic claim standard by January 1st, it won't be a 1% penalty. You won't be paid at all. Medicare, Medicaid, and the commercial carriers will not pay your claims. In our mega conference call, we asked hundreds of TMA members whether they are prepared for the deadline. A full 50% of them said they didn't even know about the new standards. Half didn't know about the standards. And we've been putting this in action and all that for some time. So it's very complicated. Basically, as an individual, you're going to have to depend on your billing software, but you need to make sure that your billing software vendor has updated it. And if you've bought something that you have in your office, you can't expect the update to magically appear. If you're online, perhaps, but the secret seems to be inquire and then send test claims before the deadline, because otherwise payment will not come. The rest of this morning we'll learn about all of these coming deadlines and more, and how you can avoid them. We have a great panel of physician leaders and TMA staff experts to lead the discussion. Please hold your applause until all the panelists have been introduced. Dr. Charles Sternberg, the Chair of the Council on Practice Management Services. Dr. Matthew Murray is a member of the Council on Healthcare Quality. Dr. Dan McCoy is Secretary of the Board of Trustees. Dr. Gary Floyd is the Chair of the Council on Legislation. Dr. Joe Todd is the TexPAC Board Chair. Lee Spangler is our Vice President of Medical Economics at TMA. Darren Whitehurst is the Vice President of Public Affairs at TMA. Shannon Moore is the Director of Health Information Technology at TMA. And Heather Bettridge is the Practice Management Associate with TMA Consulting. I'll now ask these panels to join me on stage, and we'll start the process. Each panelist will present on one of 5 topics. We will see more demonstrations on the Calendar of Doom webpage. If you have questions, please hold them until all the presentations have been made. We will have ample time for Q&A. Remember, use the 4 microphones that are there so we can hear you and the rest of the audience can hear your question. And the TMA staff will be available at the table in front of the stage during the question and answer period to answer questions. We'll also take questions from the Twitter community. Somebody will. I'm not that good at that. We'll also be sure you post your tweets to the conference hashtag listed on the screen, TMA Fall. So let's start the presentations, and we want to thank our staff for joining us. Charlie?
Thank you. I'm Charlie Sternberg, an otolaryngologist from Houston. I'm going to speak to you for 5 to 6 or 7 minutes, my allocated time, on ICD-10. Just so, since I only have a few minutes, I'm only going to make a couple of points. What is it, and why is it extremely important to you, and also what the deadlines are for it. How many people have heard of ICD-10? So most everybody has heard of it. Hopefully you're well on your way to beginning to learn about it. We still have a couple of years to implement it. As you see here at the bottom of the slide, compliance date is October the 1st, 2013, which is about 2 years away. But you really need to get started now learning it. Basically, ICD-10 has been around for a long time. It's just that the United States and United States physicians have not been using it. Other countries have been using it. It is basically ICD-9 expanded. Everybody recognizes this book. It's ICD-9. You got it. Everybody has it in their office. It's one book. Granted, it's about 4.5 to 5 inches thick. ICD-10, take this and multiply it times 5, 6, or 7 books. That's what you're going to need, or that's what you would get if it's even available in book form, and it probably will be. It's basically taking the 9 codes, of which there are about 13,000, and making them more detailed to describe diseases, symptoms, etc., in more detail. Hence, you have about 70,000 codes. To do that, the code uses additional digits. You know, in your classic ICD-9 code, it has a maximum of 5 digits, 3 digits decimal and 2 digits. ICD-10 will use letters as well as numbers to go up to 7 digits. Now, this may seem overwhelming, but it's not as painful as it might seem. Here's an example of what might be done with ICD-9. The old code for a retained foreign body or sponge in the belly or something like that was 998.4. ICD-10 has 50 codes, and you'll use 5 to 7 digits to code it. So that seems a bit complicated, but it is important. And I want to stress that in addition to being prepared for 5010, like Dr. Malone just addressed, by January 1st. You have to have that in place first, of course, and then you're going to put your codes on the bills that you send. So in order to get paid, you're going to have to use this by October of 2010. You won't get paid and there won't be an extension. It's not likely that there's going to be an extension of the deadline. So let's talk about importance. Obviously, you probably already realize that it's going to affect your bottom line if you don't do it and you don't do it right. There's two components to it. You need to train your staff, but you need to learn it yourself. Now, some of you probably do your own coding. I do a lot of my own coding. In fact, I do all of my own coding. Some of you have staff that are professional coders that do it for you. Either way, they're going to have to learn it. Now, what's important here is documentation, documentation, documentation. And here's why. If you have staffers do your coding, they're not going to know to what level of detail you want coded unless you document very specifically in the chart what's going on with that patient. Here's an example. Go back one slide. How do we do that? Diabetes mellitus. When you use the code, a coder may report 25000. If that code is assigned for all of your diabetic patients, that means they're all relatively healthy diabetics. And that means the database in the future will show that you only deal with healthy diabetics. Thus, your future earnings will reflect that fact. So you get my drift here? I'm going to use, since I'm an ENT doctor, I'll use an example from my own specialty. It's a little more clear to me. Common swimmer's ear. All you FPs see it all the time. 380.10. Well, in the future, there'll be perhaps cases, I've seen them occasionally, where it's not only painful and draining, but there's cellulitis of the whole side of the face, lymph nodes in the neck are swollen and tender, the patient has fever, is just sick as hell. And I've even seen occasional patients like that have to be hospitalized for IV antibiotics. 380.10 ain't going to cut it. Neither is documentation, just swimmer's ear, cortisporin going to cut it, or something like that. I mean, let me use a bad example, good example. I'll pick on my father, an old eye, ear, nose, and throat doctor that graduated from medical school way back in the 40s. When I looked at his charts over the years, occasionally, he's now retired, I would see a patient come in perhaps for swimmer's ear. There'd be two lines on his record. AD, OE, dash, cortisporin. That's it. AD, right ear, OE, otitis externa, cortisporin. Well, we can't do that anymore. You're not going to get paid, or if you get paid, it's going to be at the minimum level. And so how we address that, and my own practice is just now converting to electronic medical records, which I think is going to be extremely helpful, is documentation, documentation, documentation. All right, I think I've used about my 5 minutes. You need to be sure about the 5010. You need to evaluate your current technology. Become familiar with the coding itself. It's really not that painful. I've already noticed that H60 through H95 in the ICD-10 codes cover everything that you could ever document about the ear. In other words, it is organized. It's not just a plethora of codes out there. You really ought to audit what you're doing now and arrange for training. And I'm not advertising for the TMA, but the TMA does have expertise in training you and your office personnel in this. I think I've used my 5 to 7 minutes, so I'm going to turn it over to Dr. Malone. Thank you.
I did want to expand on some of the services that TMA is going to be offering. We will continue offer coding training that, as we do now on E&M services, where we come on site, train your staff, as well as performing medical record documentation, in which we look at your actual documentation and evaluate whether or not the level of service billed has been accurately supported by documentation within the medical record. But there are two new programs that we will be developing. One is for both physicians and staff, and that's going to be a hands-on workshop, not just a lecture seminar, but excuse me, a hands-on workshop in which attendees will code sample medical record documentation using the ICD-10 code sets. And the second is going to be a physician-only program, which will be in the evening, so after clinic hours, and that will focus specifically on documentation for ICD-10 and the new requirements, and how your current documentation techniques may need to be modified in order to satisfy those requirements. So as Dr. Sternberg said, it's extensive education of physicians, other providers, as well as staff and your patients is going to be critical. Okay. Thank you.
Thanks. We'll now hear from Dr. Matthew Murray.
Thank you. And also Shannon Moore, the Director of Health Information Technology for the TMA, is here. We're going to play tag team a little bit. We have about 2 minutes for 3 federal incentives in total. So we're going to go through them quickly at a high level. First of all is the EHR, sorry, let's get the slides going. The Electronic Health Record Incentive Program. And this is a program that awards incentive monies to physicians who meaningfully use electronic health records. And this is demonstrated by meeting a specific set of metrics that CMS has put out. And in the first year, over a 3-month period, we are to submit the results of those objectives to CMS in order to be eligible for the incentive. And also in the first year, it is through attestation, as opposed to submitting the actual results. In the first year, you can see that if this year, over a 3-month period, you have successfully met the meaningful use objectives, that you would earn $18,000 as an eligible physician. And then in subsequent years, there is a different amount of money that goes on, so that if you have the maximum amount of, if you're at the maximum potential amount at the end of the 4 years, 5 years, you would have $44,000 in incentive payments. Same if you start in 2012, over a 3-month period, you may earn up to $44,000 in incentives divided up per year. If you do start later than 2012, we can still earn those EHR incentives, but the total amount, as you can see and going across those lines, goes down with each year. Also, though, what's not shown on the chart, and not all of the objectives are laid out for the subsequent stages to the meaningful use that we're in right now, it actually becomes a little bit harder in 2013 and 14 to meet the objectives. So the important dates on this calendar of doom is that if I wait until 2015 to implement an electronic health record, there is no EHR program incentive money available to me. And also the second part is it's not such a doomsday date to delay beyond 2012, but the amount of money goes down a little bit, and it's a little bit harder to gain the incentives. At the bottom of the slide, you can see that eligible physicians practicing in a healthcare shortage area can receive an additional 10%. A couple other things: the incentive payments are based on 75% of the allowed charges for Medicare. And so in order to qualify for that maximum amount of $44,000, you would need to have $24,000 in allowable Part B charges. And then the incentives are based on an individual and not as a practice, although there is a way to funnel the monies to your practice. In addition to the incentive payments, the doom date of 2015, not only are we not able to earn incentive monies that are out there for us, but penalties begin to be applied to our Medicare charges, 1% for 2015, and then they can go up by 1%. And you can see in the note that in addition to that, a maximum of 5% can be subtracted if 75% of the office-based physicians do not use meaningful use by 2018. So with Shannon, are the dates and the incentives and the objectives the same for Medicare?
The Medicaid incentives are slightly different. Instead of 5 years as with the Medicaid program, the incentives stretch over 6 years. And you will see that there's also a threshold volume that must be met for eligibility. Physicians must treat at least 30% Medicaid patients within their practice, and that 30% can be calculated on either patient panel or encounters. And you'll also see that the program is very front-loaded. $21,250 for the first year, and really you don't even have to meet meaningful use the first year. You just have to what they call AIU, adopt, implement, or upgrade your EHR to be eligible for those incentives. If you'll go to the next slide, you'll notice that for pediatricians, the threshold is slightly lower. It's 20%, and therefore the incentives are 33% less over the 6 years of the program. Now, 2016 is the last year that you can begin to participate in this program and receive the full incentives. So keep the dates in mind. You can start now or wait till 2016 and still receive the full incentive. And if you'll notice on the next slide, this is Dr. Denise Casper from Bridgeport, Texas, a family medicine physician. She has gone after the Medicare incentives. She did achieve meaningful use, and she has received her incentive payment. So my message to you is that the incentives really are rolling out. Physicians are receiving money for these programs. In fact, Texas physicians to date have received $30 million since these programs began this year.
And on to the e-prescribing program, Medicare program. These are incentive payments that physicians who care for Medicare patients can earn for e-prescribing. And CMS, in order to demonstrate that we e-prescribe for patients, CMS has the program by which if we e-prescribe for 25 patients during the calendar year, then we are eligible for the percent increase in payments for that year. There are 3 different ways to submit the information, but the most common, and in my opinion the easiest, is through the claimed-based reporting of the G code 8553 as mentioned on this slide. So you can see that for 2011, if I e-prescribe for 25 patients by December 31st, I will be able to be eligible for 1% incentive payment. You can see each year that there's a certain amount, 1% next year and 0.5% in 2013. The program ends in 2014. Also, though, there's penalties. And as Bruce had mentioned earlier, if we had not increased or produced the 10 e-prescribing payments by June 30th of this year, we're actually subject to the 1% penalty in 2012 unless we qualify and register and submit for an exemption. Let's see, and that percent goes up each year, as you can see. There are some exemptions, as I had mentioned. 3 here if you practice in a rural area without sufficient high-speed internet, if you practice in an area without sufficient pharmacies who are set up and able to do e-prescribing, or a new one that if you are registered in the Electronic Health Record Incentive Program, that is now qualified as an exemption by a modification to the proposed by the rules that came out on August 31st.
There are a few more new exemptions, such as unable to electronically prescribe due to various laws, such as controlled substances. If you have limited e-prescribing activity or limited prescribing activity, or insufficient opportunities to report the measure, then you may also apply for an exemption. And this is the URL for the portal to apply for the exemption. You must do that by November 1st, so we're talking like 10 days. So if you think that you're eligible for an exemption, please do go to this portal and apply. The next slide shows you, and I know this is impossible to really see clearly, but it gives you an idea of what you will be asked to do as far as filling out for the exemption, and you will have to provide justification for why you are seeking that exemption. But again, November 1st, 10 days away.
Thanks. And finally, the Physician Quality Reporting System is a voluntary reporting program that pays bonuses to physicians who submit quality or data on quality measures. The program's intent is obviously to encourage physicians to document and report what we already do. And you can see that if I submit the data successfully in 2011, there is a 1% payment incentive, 0.5% for the subsequent 3 years, and again, the doom date 2015, if I am not successfully enrolled in submitting measures that the penalty of 1.5% going up to 2% can be applied. Shannon.
Yes. TMA has recognized that the easiest way to submit for PQRS is through the registry method, and therefore TMA has vetted and endorsed 2 different registries. We recommend that you take a look at these, DocSite and PQRI Wizard. The TMA member discount allows you to submit for $300 through DocSite or $250 through PQRI Wizard, and you'll notice the website on the screen, so please take a look at those programs. I think that you'll find them very helpful.
And then finally, just a few words on the regional extension centers. These were created through federal, through the Recovery Act of 2009 promulgated $642 million to establish 62 regional extension centers across every geographic region of the United States. And their intent and purpose is actually to help small physician practices select, implement, and meaningfully use EHRs in order to improve quality of care. And by the way, be eligible then for incentive payments. Just a couple of personal observations. One is that I know that I want to provide the best quality of care that I can to my patients, and I don't know any of my colleagues who don't want to do that. But number 2, a myth that physicians are resistant to change. Has anybody heard that? Or technophobic. That is a myth because, you know, if there is a tool or a process out there that can truly help me provide a higher quality of care to my patients, actually practice medicine or to improve my craft might be the better way, then I'm going to do that. We have not had trouble with the use of technologies, CAT scans, MRIs, nuclear medicine. You go down the road. However, if it impedes the way I practice medicine, doesn't fit my workflow, or really doesn't improve patient care, I'm not interested in that, and I will be resistant to change. And that's what I have found with colleagues across the state. Now, these regional extension centers, though, are established in order to help us with the challenges of electronic health record implementations, which are great. They are costly, they are complex, they introduce new risks to my practice, and especially if I am not technically oriented, that doesn't even matter. It just brings new risks that I must now manage in my practice in order to get the benefits or potential benefits of the electronic health record. And that's what these regional extension centers are set up to do. You can see in Texas the geographic regions for the 4 that are federally funded right now in the websites that are available, and you can also find this on the TMA website. The TMA has worked closely with this initiative to the point where the governing boards of each of the 4 regional extension centers consists of 50% physicians. This is the physician-governed entities in each region of the state. I'm board chairman of the North Texas Regional Extension Center. We've enrolled over 900 physicians to help them with their EHR implementation and use. Over 200 have successfully implemented their electronic health record, and about 25 now have attested for meaningful use. What's important is that these are physician-friendly, but they are federally funded contingent on meeting targets. And one of the targets is the number of physicians who are enrolled. The North Texas Regional Extension Center has a target of 1,400. We're at 900. We're confident that we're going to reach that target by the end of December. But if any of you in your regions, communities, have engaged with your regional extension center, enrolled, and especially if you've received services that have helped you select, implement, or use an electronic health record, I would just urge you to encourage your colleagues in your community to consider enrolling as well. Because if your regional extension center doesn't meet enrollment numbers, it will not receive federal funding in the next couple of years, so it would be important to do that. Anything else, Shannon?
Nope, that's it.
Thank you.
Thank you.
I just want to remind everyone that you can get all this information at www.texmed.org/doom. Okay, Dan, are you next up? Dan McCoy.
Lee Spangler, TMA Director of Socioeconomics, is going to join me. I thought I'd start off today by reading you a letter. It's, Dear Dr. Spangler, we have reviewed 20 charts and found that you are not in compliance with federal Medicare rules concerning billing and payment. We've extrapolated the universe of your patients over the last 24 months, and we have determined that you owe $458,000. Please remit payment within 30 days. We reserve the right to refer findings to state and local authorities for investigation and prosecution for fraudulent billing. Very truly yours, I'm a nurse, RN. Now, I'm going to tell you that my comments today, and I'm going to introduce Lee here in a minute, are not some article and ideas about what we're going to expect. I'm going to tell you some real-world stories about RAC audits, or recovery audit contractors. And for many physicians, this may be the first indication that they have a RAC audit, as they get a notification letter requiring repayment. So the one thing I want to leave you today is, in dealing with recovery audit contractors or RAC audits, knowledge is power. So the more you know about the process and the more you know, the more powerful you can be in helping to obviate any problems that can happen here. The first thing you need to know is that a company called Connolly has been contracted for this area to provide RAC audits. You need to know the subject areas in which they're auditing. There's a website, and they're statutorily prohibited from auditing anything that they're not authorized to do. So you need to make sure that you know what those areas are. And the reason is so you can self-audit yourself. If you know, for instance, I'll give you an example, one of the latest reports from our charges to the RAC has been on anesthesiology auditing. And they're going to be auditing, I think, time and possibly supervision of CRNAs. So if you're an anesthesiologist, it's a great opportunity to go into your practice and make sure you're in compliance with all of the time and the supervision requirements. You need to know when an audit is being conducted. You need to educate your staff to look for envelopes from Connolly and maybe get it on the website so that they get an idea what the logo looks like and they don't chunk it as junk mail. Because if that notification letter of the request for charts, for instance, doesn't get complied with, it starts to set in place a very arduous set of timelines that may put you at a significant disadvantage. You need to consider hiring an attorney and possibly a consultant early on to fix any problems. If you get an audit on certain charts and you do a self-audit and feel like there's some problems there, it doesn't hurt to get an attorney and a consultant to start to fix those problems now. Don't wait until you get a notification for repayment. Send what is requested. Don't alter any records. And I think it's also helpful in some of the physicians that I've worked with to provide some background information about your practice. Send your resume, publications that you've done, describe the patients that you take care of. Provide some unique information that could help support your documentation, even if it's not part of the documentation. Expect to receive a notice of repayment obligation. The odds are against you. I was talking to Lee. I'm going to make up a number, and I'm really good at that. It's probably 8 to 1. That if you get an audit from a RAC auditor, you're probably going to owe money back if you look at the national standards. Expect to have a very strict interpretation of coding rules. I was speaking to a group last week, and I'll tell you it was a group of dermatologists, and they were tossing around this idea about how to look at a certain code, and they wanted what everybody else was doing, and they had some fairly generous interpretation of the code. I can assure you in a RAC audit situation, it won't be a generous interpretation of the code. It will be the strictest interpretation. In fact, it may be so strict that we may have an argument that we could go after them and say, no, that's the wrong interpretation, but expect it to be very strict. We've sort of lived in a world when we go to our specialty societies that coding education is geared toward payment. You'll have these coding experts say, this is how you code so you can get paid. You need to realize that in an audit situation, it will be geared toward the strictest standard. It won't be geared in that direction. Expect that getting information from the audit contractor will be slow. It will be confusing. It will be incomplete, and it will not be physician-friendly. You may or may not be able to talk to someone on the phone when you call. You may have to leave a message and request a phone call back. Your staff will have to listen for people they don't know to make sure you get pulled out of a room to talk to them. Get that lawyer to help you fix any problems that you have in your house and to make sure you don't make the problem worse. You need to appeal. You can win. And in fact, if you look at the appeal process, physicians do appeal and win probably about 1/3 of the time.
That's correct. And the answer is really, if you think you're right, appeal, 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 appeal. You've got 5 levels of appeal. Of course, the last one's court, and no one really wants to get there. But you've got rights in the process. Don't think that this is just a situation where you are helpless.
You must stand up on principle and say, I didn't commit fraud. I know I billed correctly. And if you can show you did, you've got the steps available to you to prove it.
And you have to appeal for several reasons. Number one, if they are auditing charts incorrectly and using a strict standard of interpretation that we as a medical community feel is wrong, we need to prove that. And the only way we can prove that is through an appeal. You can go to jail. The new standard as of the first of the year, and I will tell you that it's a little bit nebulous in the way it's being instructed, but basically the take-home message is there is a, what is it called, a perfunctory determination that you've committed fraud just because you may have made a mistake. There's no longer the idea that, oh, I made a simple mistake, let me pay the money back.
Right.
No. The simple standard now is if you made a mistake, you don't have to intend to commit fraud, you committed it.
Right.
Which creates a problem as far as like forcing you to make the money, pay the money back.
So again, knowledge is power. And in terms of the calendar, if you scroll all the way down, and sometimes, even though these are all deadlines, go down in the archive, Steve. Just because a deadline passes doesn't mean that it disappears. So we've got an archive down there, and you see on September 6, 2011, right there, it says the RAC has just been approved to seek overpayments from anesthesiologists. And then it will take you out to the Conley website. Well, it will explain that, yes, we've been approved by CMS to look at this, and this is the way we're going to look at this information. So the calendar of doom is really knowledge is power. If you know, you can take steps. As Dr. McCoy stated, what should you do when you see something like that appear on the calendar? You should look at your records. I now know the government's going to be looking at this. This particular review by the RAC can go back to 2007 in terms of records. So you might have to go back to 2007 to see whether or not you were doing it correctly. Something else that I think...
Let me just make one comment, and I'm going to close. You need to be prepared to have forced repayment. You know, and that's a big deal in the small practice, because if you get a letter of $458,000 and you think, well, I'm going to appeal it, because you don't have $458,000 in the bank. You need to be prepared that the repayment can occur during repeal, and it's done through recoupment. Your money stops coming in all the while you're doing the appeal. So appeal doesn't necessarily mean that you're not going to have to deal with the economic ramifications of the audit. And the final thing is notify TMA of the audit. We need to start to collect information on what physicians are affected and what they're looking at so we can help our members. Lee's going to talk about the other issue on HIPAA.
Yeah, real quick. By December of next year, the federal government has to have its HIPAA privacy and security audits wrapped up. That's a word from the past, isn't it? HIPAA privacy and security. Just because it's an old law and those deadlines from 2003 have all gone and passed, it doesn't mean that the federal government isn't still looking at this stuff. Under the federal stimulus bill that was passed a couple of years ago, the federal government was told to perform audits of covered entities in regard to their compliance with the privacy and security provisions of the law and regulations. The government has chosen KPMG to perform those audits. There's going to be about 150 audits across the country, so if one of the Texas physicians happens to get chosen, you know that you should have played the lottery on the same day because you've got a pretty low chance of being selected. But they are going to look at physician practices. They're going to take a pretty good cross-section from small practices, medium-sized practices, hospitals, and clearinghouses. They're all going to get audited. The federal government's going to come in, if you happen to be that unlucky person, and they're going to sit down with you. They're going to conduct interviews with you and your tech people and your staff, your security officer, your privacy officer. And they're going to go through your policies and procedures as it regards privacy and security. And they're going to talk to you. Do you do this? Show us that you do it. Where are your records? You have to maintain them for 6 years. Let us see that. And then they're going to present a report, and you can click out I don't think it's, go ahead and try that one. but I think it might be find out how TMA can help. Yes, here it is. This actually explains, if you scroll down, you can see who the contractor, what the contractor was asked to do, what their reports have to look like, who they're going to talk to. It's all right here. So knowledge is power. Know this is happening, and that if someone says, I'm conducting a HIPAA audit, they may be the KPMG auditors coming to see whether or not you're doing what you're supposed to do. So that's what the calendar is all about, making you aware. And that's the benefit of knowing. And there are many, many deadlines that are going to face you. Many times we'll get calls from physicians, I didn't realize that this was a deadline we had to meet, like the 50-TED deadline that's going to hit January 1st. There are going to be some physicians that are going to find out after that deadline. Our job as an association is to make sure that you have one place to go to look for those deadlines, and that's what this calendar is all about. So with this and RACs and fraud and abuse, we hope that this will be a help for you.
Thank you.
Thanks, Dan and Lee. 2 weeks ago, I was with a friend who's a neurologist who happens to be a principal in an electronic medical record company and is kind of an expert, and he said, guess where I just went to give a talk? And I said, where's that? He said, the OIG and the FBI asked me to come give a talk about fraud in electronic medical records, saying you did things you didn't do. So here we go again. You know, you think you've documented everything completely, and now they're looking, maybe it's too well documented. So we'll see. That's the next problem that's going to come. Gary and Darren are going to give us a little insight about the political and legislative landscape or the problems we're going to see.
And Dr. Todd. Dr. Todd's going to talk about politics.
Oh, I'm sorry, Joe. You're sitting. Joe, you've got your microphone down there.
We'll trade out.
Just turn it on, and you got to have it pretty close, Joe. Sorry.
We'll trade out.
good.
It's kind of ironic that a pediatrician would stand before you and talk to you about Medicare, but that's what we're here for. Darren's always using the phrase, you want the good or the bad? You want the good, the bad, or the ugly? Well, I'm here to talk to you about the bad, the ugly, and the atrocious. And the atrocious, if I can, there it is. The atrocious is while docs have forever tried to deal with the problem at hand, the sustainable growth rate, it seems Congress stands behind us and is easily distracted and tends to just kick the can down the road, putting patches, putting what have you. First date, January 1. If nothing's done, Medicare is going to drop by 29.5%. So fixing that SGR, the sustainable growth rate, as you remember, based on a GNP, the gross national product, not based on a medical economic index. And Dr. Malone graciously earlier showed you the jaws of doom, I believe you called that, and how far apart we continue to fall for reimbursement, for payment. Now, we were in hopes that MedPAC would come up with some type of rational process to fix the SGR, get rid of the SGR and really fix the process. But their latest recommendation has been to reduce specialists about 5.9% per year for 3 years, then freeze them for 7 years, and to leave primary care physicians frozen for 10 years. Most primary care physicians and specialists that I talk to are still struggling with rising overhead and keeping offices balanced. To freeze anything, much less to reduce for several years, it's just not sustainable either. So, we move on to Joint Select Committee for Deficit Reductions. You see before you the members, 6 Democrats, 6 Republicans. They are charged to make reductions to our debt. They are not charged really to fix the sustainable growth rate. Many are trying to hang that on this committee, and this committee, I believe, is trying to shy away from that. They're trying to shy away from it because if they fix it, it's going to impact the debt even more, as you well know. You see, we do have a Texas representative on that committee. We'll see. Their charge to cut out $1.2 trillion over the next 10 years, that's a lot of zeros, 1.2 trillion. And these are the deadlines we want to talk about. The day before Thanksgiving coming up, November 23rd, that committee has to come forward with recommendations that reduce the deficit. If they don't do that, what happens? Well, if they don't do that, December 23rd, the House and Senate have to vote on their recommendations. So if they don't bring recommendations forward to reduce the deficit, $1.2 billion, then there's no way the House and Senate can approve or disapprove of that. If they do bring forward recommendations, you know how cordial the House and Senate are in Washington. It's still very unlikely that they're going to agree on whatever those recommendations are. If there is no vote or there is no agreement to recommendations to reduce the deficit, then come January 15th, they will enact what's called sequestration. Sequestration means an automatic reduction in spending. Automatic cuts, and those cuts will come in defense, perhaps as much as 50% of the defense budget cut. Those cuts will come in how they pay for health care, and it starts with a flat rate 2% cut across the board for all Medicare. Medicaid is spared. And I know some of you are sitting there going, now wait a minute, back in August, President signed this bill and they said Medicare, Medicaid, that's untouchable. And that enacted like $917 billion of cuts over the next 10 years. The problem is this super committee, as this deficit committee is called, has been given license to touch any part. They can touch all entitlement programs, they can raise taxes, they can do whatever. Now, see that in our House and our Senate. If you reduce entitlement spending, you've pleased one side of the House or one side of the Senate, but the other side's going to ask for tax increases to offset those. So it'll be an interesting debate. But bottom line, if nothing is done by January 1, 29.5% goes into effect. Now, we have pretty good indication that there's going to be a patch, 12 months, 18 months. It'll be the typical half, 1%, whatever, kick the can down the road again. But if they don't do that, 29.5% cut, boom, January 1. If they patch it and the Joint Committee does not bring forward recommendations that are approved, then come January 15th, they will enact sequestration, and that will go into play January 1, 2013. Darren?
Nothing to add. Good job.
Okay. So I put this there just to say the chances of these spiders catching the kid going down the slide are probably much better than an agreement coming.
Thank you. I'm Joe Todd. I'm chairman of the board for TexPAC. Fortunately for people like me, you do not have to be gifted to get into politics and be involved. Like this fellow's having a little trouble getting in, but we can all do it. I just wanted to go over with you what's going to happen in the coming election cycle. It's going to come fast. We had redistricting in the last session, and that occurs every 10 years, and it stirs the pot and creates a lot of opportunity for us. There are going to be about 25 open House seats. There are, I think, 3 Senate seats that are going to be open. All of this redistricting is still a bit up in the air because the courts have not ruled finally on that, and They're due to make a ruling at the end of this month, but everybody's holding their breath to wait and see what they're going to do. But I think it's going to be a tremendous opportunity for medicine to have an impact on this election. In each of the last 3 election cycles, we've been able to get one House of Medicine person elected to the legislature, one in each of those cycles. We have an opportunity in this election cycle to get 3 physician or alliance members elected to the House. So it's an exciting time. There's a lot of opportunity for everyone to get involved. There will likely be an open House race in a district near you. There are so many open seats up. The first date I want to bring to your attention is the first day of filing, which will be November 12th. That's coming up. The filing date closes a month later on December 12th, and it may be extended if they redraw some of the maps. In the middle of that, we're going to have our TMA TexPAC legislative retreat here in Austin at the Weston Domain, and I want to encourage all of you to come to that. TexPAC will be making some endorsements of some of our incumbent friendly legislatures, our friendly incumbents, and we're going to be getting everyone up to speed with the candidate briefing documents so that they can go back and interview all of these new prospective candidates so that we can figure out who to endorse. The timeline is going to be quite short because, as you know, the Texas primary is always held early in March, and between the holidays and the first part of March, we've got to get our endorsements in. We've got to get behind these candidates. We've got to do everything we can to get the people elected who understand medicine's issues and who can help us. Many of these races will be decided in the primary because all but a handful of districts in the state are very partisan Republican or very partisan Democrat. So you can't wait till the general election cycle to make an impact in Texas politics because it really all happens in the primary. So we've got a short time frame. The last day to register to vote in early voting is February 6th. So be sure you're registered, be sure your spouse is registered, your adult children, the folks in your office, because it's really important that we're able to turn out the vote when the time comes. In addition to voting, we need you as TexPAC members, we need you to be available to go to fundraisers for our endorsed candidates and get to know these people on a personal basis. And we hope that you'll even find some time to volunteer in their campaigns. After the primary, we'll have a primary runoff. There will certainly be runoffs, and we're actually going to have more time between the primary and the runoff than we did between the filing deadline and the primary. The primary runoff will be May 22nd, and then the general elections, of course, will be in the fall. And our next slide. This is how our slate of medicines candidates is shaping up. Of course, Congressman Burgess is running for re-election, Dr. Dewell, Susan King, and Dr. Zerwas. King and Zerwas in the House. Charles Schwertner is going to file to run for Senate District 5. He will be unopposed at this time, but of course filing deadline has not come around yet, and there may be others that enter that race as well. Representative Mark Shelton is leaving his House seat to run in Senate District 10. He will be challenging Representative Kelly Hancock in the primary. And whoever prevails in that primary will then face the incumbent Wendy Davis in that race. This was a Senate district that was slightly Democratic, and after redistricting, it has become predominantly Republican. Senator Davis has filed a lawsuit and challenging the boundaries of the district and the makeup of the district, and that too is still in play, and how that's going to turn out is unknown. In the Texas House, we have one physician, Greg Bonin, who's from the Galveston County area, running for the House. Sonal Butcher, also from the Houston area, Sugar Land, who's running for the House. And we just found out this weekend that Susan Todd is running for the House in
Any
District
relationship?
97. Yeah. So we've got great opportunities, and we need to be engaged and involved in this political season, and we've got a tremendous opportunity. We just want to take advantage of it. We want to get all our folks through this dangerous process and safely on our side, and that's our goal. Thank you.
Thanks, Joe.
You know, actually, Dr. Malone, what I would also echo is, you know, time. You think that you always have time in these types of election cycles. He talked about the primary. The primary is 136 days away, so it will be here before we know it. Polls close at 7 o'clock, so it's basically 136 days, 8 hours, and 7 minutes until polls close. Everywhere but El Paso, the polls will be closing at that point in time. And then the Texas legislature begins their work in 444 days, 1 hour, and 6 minutes. So it will be on us before we know it. So again, I would echo what Dr. Todd said, is that we need all of y'all to be involved, but we're preaching to the choir up here. Really need you to be talking to your colleagues back home. Make sure that we get those candidates elected, because it makes a huge difference in the legislative process to have people that actually understand medicine, have lived medicine in the legislature. So,
Thanks, Darren. I'm going to take a president's prerogative, and we have 5 minutes that if anybody has any questions, and I'd like to start out with Dr. Sternberg and ask, Dr. Schneider presented at the AMA delegation meeting this morning a resolution they're going to present based on the pediatricians. It turns out that the ICD-10 is going to be a huge technical issue with the adoption of the electronic medical record simultaneously. And I didn't know this until this morning, but I guess ICD-11 is coming out about 7 months or 8 months after the deadline for ICD-10. And so the resolution is going to actually ask that we petition to delay the implementation of ICD-10 because, as you say, it's been in Europe for a while, and the new ICD-11 is coming so soon. The question will be, shouldn't we wait? And is there any opinion you have about that?
The Department of Health and Human Services is the federal department that mandates ICD-10. I'm not aware that they're going to mandate ICD-11. I'm going to ask Heather to help me address this question.
I have not heard that there is going to be any delay. I have heard about ICD-11 soon coming, but that was not going to delay unless I hear something different, that we're still planning to move forward with ICD-10.
Oh, believe me, it's not in the plans, but that's just I'm just pointing out there's going to be a resolution submitted to the AMA to try to have the AMA help with, I mean, it doesn't make any sense to me to institute something if they're going to have a substitute for it in 7 months or whatever
Right.
it is. I'm not sure of the exact details, but we'll deal with that later. Finally, Dr. Murray, we saw this nice presentation of the repayment program, or the payment program for electronic medical records. Do you think with the current budget crisis that in 2014 there will be any money left to distribute for that?
This might be a loaded question. and actually, I just got before I answer that, I just got a tweet, and it says that YouTube, Twitter, and Facebook have just combined into one large social media company. It's called UTwitface. Anyway, I had to share that one. The money for the EHR incentive program was designated in the Recovery Act of 2009, and that money, as far as I am aware of, is not part of the budget reduction conversations, and looks like it is protected. Now, it's not protected, that's the wrong word, but it is already budgeted for and part of the current budgets. Nobody could say that it couldn't ever be touched, but my personal opinion is that CMS, the government, do want to help physicians in the healthcare industry implement electronic health records for not only the quality initiatives, but hopefully some cost reductions or at least cost neutral while improving quality of care, which then thereby reduces healthcare costs. So it is opinion, but I do think that there is enough on both sides partisan support for promotion of electronic health record adoption that is of a less priority for them to cut. Shannon, do you have any other opinions or information on that?
No, I agree with what you say. I think that that's probably a lesser priority, and certainly when you look at the unobligated funds in the HITECH Act, it really is the physician incentives, but I do think that those will stand clear because all of the other funds that are obligated are meant to support the EHR adoption for physicians. So I really do think those funds primarily are safe. That said, anything could happen.
Well, that's good news for doctors. Thanks. Yes.
If you look out there, what people are already overwhelmed in their offices, just trying to file claims, trying to deal with all the regulations. So the question becomes, how do we help practices in the state of Texas deal with all of this? And I think one of the things is that TMA really has to pull out every single tool that we have at this point that simplifies people's practices, that helps them in the office to deal with regulations, that helps them in the office to cut practice expenses. So pulling out every tool that we have, thinking of what new tools we have, and I think more importantly, making sure that all of this is known by the individual practices out there in the state, and whether that be by Texas Medicine, on the internet, through the county societies, wherever it is, because nobody is really looking at how individual practices are going to deal with this, and it's going to be nearly impossible unless we figure out how to find time in those practices and efficiency in those practices to deal with it.
Well, Susan, you're absolutely right. That's one of the reasons we had this program today, and stay tuned with action. We'll always pound and pound and pound on action, and if you don't get it sent to your email daily, do, and of course we'll have it in our published materials also. Yes, thank you.
Hi, I'm Beverly Knuckles from New Braunfels, and my new neighbor, Donna Campbell, is going to run against Jeff Whitworth, so we might have another doctor in the Senate.
Thank you. Well, we think that this leadership team at this table and the staff supporting them are one of the ways we can get us away from the doomsday scenario. This concludes our conference programming. Don't forget to turn in your CME forms and conference evaluations. And don't forget your 3-2-1 assignment to replace the SGR. Drop 3 postcards in the basket behind the ballroom. Take 2 sets home to distribute to your partners or colleagues, and make 1 phone call. We'll see you back here in Austin on January 27th and 28th for the TMA Winter Conference, or December 2nd and 3rd for our advocacy conference that Joe just mentioned. Thank you, and have a safe trip home. I am proud to be president of this dedicated organization. Thank you.